outline, we're going to talk about these three different things. And I just kind of want to show of hands who here has a laryngeal dystonia. Okay. Who has a vocal tremor? And who has muscle tension dysphonia? Okay, great. Those are the things we're going to be talking about. So we have a good showing. And so if something, you already know about, I'll try to get through it quickly, but since everyone has a very different background, I might talk a little bit about your disorder. Okay. So what is Botox? Botox is a component that makes muscles weaker. Okay. So sometimes it's hard to think. So if you're making the muscles weaker, how does it make the voice stronger? And the idea for each of the different pathologies we're going to talk about is there's a different thought process to why the Botox works. So I'm going to start off with laryngeal dystonia. It was formerly known as spasmodic dysphonia. We don't call it that anymore because it's not actual spasms of the muscle. So we originally thought as a medical society that it was a problem with the muscle, that the muscle was spasming, and that's why the voice was sounding the way it is. But over time, we started to learn that it's actually a neurological problem. It's a brain processing problem. And so paralyzing the muscles, it's not meant to stop spasms. It's meant to trick the brain. It's like a sensory trick. So when we use Botox doses, we actually use super, super, super small doses that don't actually paralyze the muscle, but it changes a little bit the signal that the muscles are giving the brain and tricks the brain to do the right thing for a while. That's why sometimes people have their Botox last 2 months, even though we know that Botox lasts 3-4 months. And sometimes people only get an injection every 6 months, and we know the Botox is gone, but they were able to trick their brain a little longer. 2 different types of laryngeal dystonia. The one that's more common that most people will have is the adductor type. So that's when the vocal cords are closing out of your control. So that is a lot more strangled. So you hear a lot of the breaks of the voice where you're trying to say something and it closes off on you. Less commonly, in about 20% of people with laryngeal dystonia, is the abductor type. That's when the vocal cords are opening when you don't want them to open. So that sounds like sometimes people think you're yawning, but you'll be saying a sentence and then it'll get breathy, right? Dystonias are better with singing, humming, and sometimes they're responsive to alcohol. So a lot of our research now is seeing if we can use medications that are similar to alcohol without you being drunk all the time. So, and then it gets worse on the telephone and with anxiety. So a lot of times it's interpreted as, wow, they sound like they're really anxious. You're giving a presentation, your voice is getting worse, when maybe it would get a little worse anyways, but it's exacerbating the disease. So it took a long time to realize that it was an actual neurological disorder and not just anxiety. So Botox techniques for adductor, so that's the actual vocal cords are closing. The muscles in the vocal cords are what we're tolerating. Who here has had a Botox injection with the EMG machine, the one that makes a lot of noise? Okay, so you guys are familiar. So here we have a larynx. This is the voice box, the thyroid cartilage. This is the airway. And there's a membrane right between them that tends to be nice and soft and easy to get through. And so here are the vocal cords kind of protected here in the voice box. And this little shadow is the muscle, the thyroarytenoid muscle or the vocal cord muscle. And so the needle goes into this membrane and we actually have to make it go up and kind of out to each side to inject each vocal cord. The EMG, what the EMG is doing is giving us the signal from the muscle when it's activated. So we use EMG for all sorts of different things. So we ask you to do whatever it is that muscle does, right? So in your cases, a lot of times you're saying E or some sort of sound because that's going to activate the muscle. And that's how we know we're in the right muscle. Okay. Now, for the abductor, when the vocal cords are opening and giving you that breathy sound, that's a different muscle. So that's a muscle in the back of the voice box. So again, voice box here, it's this muscle that opens the vocal folds, and it's the only muscle that opens the vocal folds. And so here's a picture of the muscle being, the voice box being twisted over so that you can see the back of the voice box, and this muscle is the PCA muscle. So there's two ways, again, to inject. One way is to actually hold on to the neck, twist the voice box over, and go through the side. And we, again, use the EMG, and we have people sniff and say E so that that muscle is activated and deactivated. So we are now we're in the right place. The other way to do it is, again, through this membrane and going right through the voice box, through the airway into the muscle. When you do this, most of the time, you also need a camera or a scope so you can see the needle and what you're doing, because it's a really far path for the needle. And oftentimes we'll combine the EMG so we can have that auditory feedback that we're in the right muscle, as well as the visual feedback. Some issues with this is that the needle can get plugged with cartilage as you're trying to get through the cartilage to get to this muscle. But again, there's a couple different ways, and we work with patients depending on what's more comfortable for them. Like, some people hate the camera so much that that is not an option. And some people feel like if you're twisting the larynx, it's uncomfortable. So we don't want to make anybody uncomfortable. For this, you do get numbing of the throat so that you don't cough when that needle is going through your airway. So with Botoxing actual laryngeal muscles, we get a breathy period after the injection. And the idea is to have the shortest breathy period possible with the longest good voice possible. So most of you have been through this and tend to be really good at knowing, exactly when to get your Botox done. So when it's your daughter's wedding, you're right here in the middle at the best voice. So here, breathy starts to get better, normal, and then starts to decline as you need your next injection. And again, with Botox, there's not just one dose, because everyone is a little bit different and everyone needs a little bit of a different amount of Botox to trick their brain. And so sometimes it can get very frustrating, as some of you know, because we have to try different doses. We start off with a really little dose. Maybe you get no breathy period, but then you only get good voice for a week. So that you can't do that every week. It's, too often. So then we increase the dose, and sometimes we overshoot, and then you have a breathy period for a month, and maybe that's too much. And then for different people, they have different goals. So my patients that are driving really far, because I'm in Tampa and people drive 4 or 5 hours to get their Botox, they'll be like, well, I'm okay with that month or 6 weeks of breathiness, because then my Botox lasts 6 months, and then I only have to come to see you twice a year, which is their goal. Other people are like, you know what? I'm a lawyer. I cannot have a breathy period. I need my Botox every 2 months at a very low dose so that they maximize. So it can be frustrating, but we work together and find a place where it's good for you. And as you know, I'll do it every month if you wanted to, but it is work for you to come in and have a procedure, and especially with people who have jobs. So then the next disorder I'm going to talk about is essential vocal tremor. So also a neurological disorder coming from the brain, and can affect multiple parts of the body. The most common is the head and the hands. So with vocal tremor, it could be any muscle affecting the voice. So you could have tremor of your palate, and that would give you a vocal tremor. But injecting your vocal cords with Botox is not really going to help, right? Because that's not the issue. So with tremor, we have a little bit more creativity as to where we're injecting based on what exactly is contributing the most to your tremor. There are now a lot more therapy techniques for tremor to help learn about how the voice is being produced and how to kind of work around the tremor to make it as little as possible, which has been very, very helpful. And medications so far have not been the best because they'll help a lot with some of the other tremors, but the vocal tremor is kind of difficult to subside with medications. So I have a couple of videos of different kinds of tremor that I want to watch with you. So we'll watch the video and I will point out some of the tremors, okay? So one of the things we notice is this tremor is coming from the outside in, more lateral, medial lateral. And we can keep watching this video again. I think it's a long video, but you see the tremor in certain spots. And then you also notice the sidewalls of the throat are also tremoring. Those we can't Botox, you won't be able to swallow. And so we have to find a way where we can Botox, but also keep our function, because Botox weakens muscle, so we get side effects, and we want to minimize those side effects. For the dystonias, when we're Botoxing the actual vocal cords, the side effect we're talking about is the breathiness. Okay. So for this patient, what I'm seeing that could be Botoxed is we could Botox the actual vocal folds. We can also Botox the false vocal folds, because if you notice, those are also contributing to the tremor. And tremor is that very rhythmic sound. Unfortunately, with dystonias, a lot of times you get tremor, and so you get to have both voice disorders. But that way we can be a little creative with where we're injecting the Botox. So for tremor for this patient, I injected the false vocal folds, because the nice thing about injecting the false vocal folds, they're right here and here, is that you don't get breathiness because you're nice and far away from the vocal fold, but you do get a benefit from some of that lateral tremor coming in. And you can use bigger doses, and oftentimes that is the best option. We can do that multiple ways. We do need a camera because we cannot use the EMG for those muscles, because they do very similar things to the vocal folds. So you kind of don't know where you are. So we have to be able to see it. And either it can go through a scope, so a channel scope with a little tube in it. You can put a endoscopic needle and inject both vocal folds, and I have a video of that. Or you can also go through the neck with numbing similar to the EMG. So this is an example of false vocal fold. I always have students, so I'm always explaining what I'm doing and talking to the patient, and I just don't want to listen to my voice. And so here it is going through the camera. So all you're seeing is the channel and the needle. And we are Botoxing both sides. And again, we can use a little bit more because we're nice and far away and there's less side effects here. The other thing for tremor to notice is I always look at the vocal folds and whether they're thin, because if the vocal cords are very thin, it takes more effort to get voice out. So you're really squeezing with those false vocal cords to try to get your vocal cords closed. And I always use the example for patients of when you're at the gym and you're lifting something too heavy, you start tremoring. That's normal, right? And so if you have tremor plus your vocal cords are thin, a lot of times your tremor is exacerbated because you're working so hard, and plumping up the vocal folds with a filler material, which is the opposite of Botox, right? Filler makes it bigger and plumpier, and Botox paralyzes, can help with the tremor. So we can be very creative with tremor and look at multiple different things. It's not as straightforward as laryngeal dystonias are to treat. So I can plump up the vocal cords for some patients and do the false vocal fold Botox, for example. Vertical vocal tremor, that's when the voice box is going up and down. And so a lot of times when a student is looking for the first time they're learning how to scope, they feel like that their scope is going in and out, but it's not, right? They're holding it in place. It's the voice box that's coming up and down. So you'll see that the voice box gets closer and further away from you. And the muscles that move the voice box up and down are actually the swallow muscles. So if you put your hand on your neck and you swallow, you should feel your voice box go up and then come back down. So with a vertical tremor, if your voice box is going up and down, we can actually Botox some of these swallow muscles, and they're on the outside of the voice box. And so this is a anatomical depiction of all the muscles, and they're all color coded for medical students to learn. And sometimes it's the muscles above the voice box, and sometimes it's the muscles below the voice box. So this is actually useful to use the EMG because you can see which muscles are contributing the most with the tremor when you have a patient say E. So I'm going to show you a little video of someone with vertical tremor. This was my short clip, I forgot. So I'm just going to have to replay it for you. But you see the whole voice box is bouncing up and down. So if I were to Botox this person's vocal cords, well, I'm going to make them breathy, but not really make that much of a difference to their voice. And then the last disorder that I use Botox for, that we use Botox for as a community, is muscle tension dysphonia. Who knows what that is? Good, well-educated crowd. I like it. So this is one of the most common voice disorders, and it occurs when the muscles around the larynx, around the vocal cords and the voice box get really tight with speaking. And the interesting thing about this is that it's not a certain kind of voice. So it's not always strangled, always breathy, always rhythmic. It depends on how the vocal cords are being held. So a lot of times with muscle tension, you get that really strained, strangled voice. And some people even think it's a dystonia. But also, sometimes the muscle tension is kind of guarding the vocal cords and holding them apart. So they'll come in and they'll be so ready. We are educated to learn about different voice disorders and how they sound. And we have some ones that we know that are very consistent, like dystonia and tremor. And if it kind of doesn't really fall into a category, I'm always thinking like this might be muscle tension. Muscle tension, for the most part, we treat with therapy because you can behaviorally teach muscles how to act. And so this is primarily a disorder that we send to our voice therapist and our speech language pathologist, and they do really wonderfully. When we're evaluating a patient with muscle tension dysphonia, we're evaluating how well they're going to do with therapy using a few little techniques as we're doing the evaluation. We call that stimulability. Is this person going to be able to behaviorally change their voice? We do it for all disorders all the time, but especially for muscle tension dysphonia, because we don't want to send someone to voice therapy when we know they're not going to benefit. And sometimes you do 1 or 2 sessions and you realize this is not going to work. This is not something that's easily going to be changed behaviorally. So then they come back to the laryngologist and say, well, what can we do to make it easier for this patient to do therapy? You don't get out of therapy. You still got to do therapy. But Botox can be helpful. And I inject the false vocal folds again, because if you see this, I'm going to play this video, but we should be seeing the entire vocal cord when someone is saying E, similar to that video that Darla presented, where you see the whole vocal folds and you see them come together and vibrate. In this video, we're not seeing the whole thing because the muscles on top of the vocal fold are being activated. So you're seeing these muscles are coming in, and the top and the bottom here are also squeezing in. So there's different types of muscle tension dysphonia. We always differentiate between, is it coming in from the side? Is it coming in up and down? Or is it concentric, or all of it is squeezing in? So I will Botox the false vocal folds, similar to what I showed you with tremor, here and here, to kind of force those muscles to relax and stop working so hard. And oftentimes you do that for someone with muscle tension dysphonia, and then their voice disappears because they've been using these swallowing muscles to talk for so long. But then it's easier to then relearn how to speak because those muscles aren't engaged. And again, most of my patients with muscle tension dysphonia go do therapy and do wonderfully. This is like 1 in every 100 patients who can't get the therapy to work. So we do a medical intervention to help them do the therapy. Okay. So this is the last one that I was going to speak about today.
And my doctor said that sometimes the quality of the Botox may not be effective. Do you ever have that experience?
So obviously, theoretically possible. Botox loses its effect the longer it's been sitting out. We keep it in the fridge. So even with cosmetic Botox, you always want to ask them when they open their vial, because you want to have your Botox that day, because that's going to be the most effective. If it's been open for a week, we aren't supposed to use the same Botox multiple days in a row just for infectious purposes. So personally, I always open a new vial, but I don't know how it's done. So that's something you can ask. If it's been consistently not working as well over the last few times, I would assume that that's not bad Botox. That's usually like a one-off. Probably means your dose needs to be adjusted, because after you go through that whole thing where you figure out the dose that's right for you, you can also change. And your dose might be, adjusted. And sometimes we'll do Botox on only one vocal fold and increase the dose. Sometimes we do both, and we play around with the doses. And even people will tell me that they've been getting Botox for 20 years, and then all of a sudden the dose didn't work, and then you have to adjust it. So that happens, and that's not uncommon. And so that's what I would think, as opposed to the Botox being bad. But you're bringing up a really great point that I was actually going to say to answer her question, is that very, very rarely people can start developing antibodies against the Botox, especially if you've been getting it for so long. So that's another thing I keep in mind. Sometimes I change the brand, or I change which Botox I'm giving to see, is it not effective because your body's not tolerating it anymore? And a lot of times I'll tell my patients, if they're also getting cosmetic Botox, to try to do it very close to their laryngeal Botox, so that the body doesn't have multiple times where it can possibly reject it. Very rare, very, very rare. So similar to what Dr. Bensusan just said, every surgeon is a little bit different in their technique. So I'll tell you what's better in my hands. That might not be what's better in your husband's physician's hand. So take it with a grain of salt. For me, going through the voice box tends to be more effective because I can get it in the heart, in the meatiest part of the muscle, versus on the side. I find myself injecting what I think is the edge, because I'll get less of a good result. The other thing is, just like with any other dystonia, you're playing with the dose. So you can, for PCA Botox, you can also inject both sides. I never inject both sides at the same time, because sometimes people can't breathe, and that's bad. So I will inject one side and have them come back later in 2 weeks when the Botox is in full effect, take a look with the camera, hear their voice. And if their voice is good, then we can just always do one side. And I'll alternate sides if I do that. If it's not good, then I will inject the opposite side, but at least I know what the first side effect is, so I don't overdo it and give someone an airway problem. And so it really, you have to work with your patient. You know, it's not one size fits all. There are doses that we historically start with for different muscles, just based on the size of the muscle. But for some people, it's too much, and for some people, it's too little. And then it can change over time, like we were talking about. So you can have a good 10 years of we're doing this over and over. You're used to it. And then suddenly it doesn't work. And then you have to have a conversation with your doctor. Do we change the dose? Do we do it one more time and see if maybe this was just a one-off? And sometimes you change, you do more, you do less, you do both sides if you were only doing one side, and you kind of redo that initial phase where you're figuring it out. And it can be frustrating. I have patients that it takes over a year to get them a good dose because we're doing it every 3 months. And so you're only getting 4 shots a year. So it's not like we're doing it every day where we can tweak it in a week and get to the right dose. So sometimes it takes years. And you can always get second opinions from different laryngologists because remember, we're trained all over the country from different people. And even though we go to conferences and we talk and we do a lot of things the same, different people have different experiences. So I always tell my patients, get a second opinion, get a third opinion, and then decide what works best for you. Thank you so much.